Okay, there are common problems for any central venous therapy access device. Infection being the first and foremost because it is an invasive procedure, so you should know the signs and symptoms of an infection by now. So we're not going to review those. Sometimes it's just a problem with the catheter itself. If you use serrated hemostats or anything that can eventually cause a tear or a hole in the silicone that's used or whatever the device is made out of, then you have some problems there. Blood and fluid, um, blood may back up and the fluid may leak. You could have an air embolism that could occur if there's a hole. So use anything that's non-serrated. And you're always looking at the catheter to make sure that there are no breaks or cracks that may cause it to have to be replaced. Sometimes the line is just kinked, and it can be kinked on the outside of the body or on the inside beneath the skin. So anytime you're accessing a central venous access line, also you're looking for any complications that there may be like that. If it becomes kinked beneath the skin, it's only detected by x-ray, and it's usually between the clavicle and the first rib. And sometimes it has to just be repositioned or sometimes just removed and a new one put in. You are to never attempt to straighten any kinks unless it's something invisible on the outside that is easily done. If you think the line is kinked beneath the skin or you see that it is via x-ray, you are to never try to fix that yourself. That is up to the practitioner to do so. You can do them, like I said, externally. You can retape or try to position it so that it's proper. Remove any loops or kinks that there are, so that it doesn't cause any other problems. Now, let's see. One of the common problems is a pneumothorax, and it's the most common traumatic complication of catheter insertion, especially into the subclavian or internal jugular vein. It's usually discovered via x-ray that confirms that the catheter is not where it's supposed to be, even if the patient does not have immediate symptoms. So that's again another important reason to have an x-ray as soon as the device is put in. It could be a very minute pneumothorax and may not require any intervention. They may have to do a thoracotomy, put a chest tube in if the pneumothorax is severe enough to cause signs and symptoms like chest pain, dyspnea, cyanosis, decreased or absent breath sounds. Those are all ding 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 warning signs, especially if the person's just had a central venous access device placed. So you have to be aware of those. So initially, a person may be asymptomatic, and then the signs of distress may show up gradually as the pneumothorax itself gets larger. You have to monitor the patient very closely for at least 8 hours after the catheter has been inserted, and you're doing that by auscultating breath sounds. So if it's a pneumothorax is there and it goes unchecked, it can develop into a tension pneumothorax, which is a medical emergency. And we'll talk about those things when we talk about respiratory. Your signs and symptoms then of your tension pneumothorax are acute respiratory distress, asymmetrical chest wall movement, and possibly a tracheal shift away from the affected side. So those are all things that you need to. Now, there are some risks associated with central venous therapy, and they are listed for you on pages 118 through 120. I do not want you to memorize these things. I do want you to read over them and be aware of them. Local infection and systemic infection, those are things that you do need to know, and you should already know some of the signs and symptoms of infection itself. And I gave you specific things about a pneumothorax, so I do want you to know those as well. But as far as knowing everything on the charts from page 118 to 120 is not necessary, okay? Now, before we move on to pick specific complications, I do want to talk about the second most common life-threatening complication during central venous access therapy, and it is an arterial puncture. This is on page 120. The arterial puncture can lead to hemothorax and internal bleeding, and it again may not be detected immediately. A hemothorax is treated like a pneumothorax, except the chest tube is inserted into the lower chest to help remove the blood from the chest cavity. If untreated, internal bleeding caused by an arterial puncture leads to hypovolemic shock. Okay, so at this point you should know what hypovolemic means. The signs and symptoms then of hypovolemic shock include increased heart rate but decreased blood pressure. Now think about that. This person basically is bleeding out. So the heart is working harder because there's less blood volume for it to pump around, but the blood pressure is falling because there's less blood. So less blood in the system makes the blood pressure fall, but makes the heart work harder. It's trying to do the same thing with less volume than it previously had to work with. Also, cool, clammy skin, obvious swelling in the neck or chest, and mental confusion, and then the formation of a hematoma. Okay, so all of those things are signs and symptoms of the arterial puncture, hypovolemic shock, that it goes along with the arterial puncture. Okay, so now we're going to move on to PICC line specific complications. So phlebitis. Mechanical phlebitis is just a painful inflammation of the vein. It may be the most common PICC line complication. Usually occurs about 72 hours after insertion, and it's more common when the larger gauge needles is used. Okay, just painful inflammation of the vein. If the person then has mechanical phlebitis, warm moist compresses, elevate the extremity, restrict activity, and if it's continued or it worsens, then the catheter is going to have to be removed. Bacterial phlebitis can occur with PICCs. Usually occurs later in the infusion therapy. There's drainage at the insertion site. It's probably going to be purulent, and they may have spike of temp. So in this case, it may have to be that the PICC line is removed also. There may be minimal bleeding after a PICC line insertion for the first 24 hours. If bleeding continues around the line, there needs to be an evaluation. It should have a pressure dressing for the first 24 hours, and then if no bleeding, it can be changed to a new transparent dressing. So the next complication then is for ports. Let me mention if there is a need to remove a PICC line and you happen to be the one that does it, then first of all you make sure you have the correct order and the correct patient that you have to have, and then make sure that you have a backup in case there's a complication such as uncontrolled bleeding, especially if the patient is on anticoagulants. And then make sure he understands. Turn the face away from the catheter site, and then he's going to perform the Valsalva maneuver when it's being withdrawn. Remember, that's done to increase central venous pressure and to prevent air emboli. Okay, so just remember those things. And then with documentation, how the patient tolerated it, the condition of the catheter, including the length. Those things are measured before they're put in, so they have to be measured when they're taken out to make sure that you have the entire catheter. The time of discontinuation, any cultures that were ordered and sent, and then dressing applies, and anything else that is pertinent to the removal of it. Okay, so we talked about ports a little bit again for chemo fluids, pain control meds, blood, TPN. It's either done by a top entry or a side entry to access the port. In the top entry, the needle is inserted perpendicular to the reservoir, and in a side entry, it's inserted almost parallel to the reservoir. The top entry is the most commonly used. I've never even actually seen a side entry for those. the type of reservoir that's used is typically titanium, stainless steel, or molded plastic. It depends on the patient's therapeutic needs. So if a patient needs to undergo an MRI, they have to have titanium and plastic instead of stainless steel, so that you get valid test results. So when inserting an implanted port, the doc makes a small incision, puts the catheter in the central vena cava through the subclavian, jugular, or cephalic. They do use fluoroscopy, and then he has a little sub-Q pocket over a bony prominence in the chest wall. That's where the device will sit. There is an incision, so that must be monitored for 7 to 10 days for signs and symptoms of infection. Any of these procedures for a central venous access insertion do require consent because it is an invasive procedure. Afterwards, you have to remind the patient that the device is in place and that he needs to carry something with him that tells the specific care protocols, the serial number, and the model of the implanted port. So if he has to have any other kind of procedures, everyone's aware of what he has in as his central venous access device. The patient with a port may need to get prophylactic antibiotics before any dental or surgical procedures to prevent contamination, and he has to make sure that he tells his dentist or practitioner about the device, and that's the importance of him carrying that card so that he has all the information for that person. Remember that a port can be used immediately after it's placed, but because of swelling and tenderness, it's usually not used. Usually for 7 days. 72 hours is a good time frame, but most physicians don't want it used for at least 7 days, so that the patient is comfortable with it and the swelling has decreased and that there's no pain associated with it. Makes it more comfortable for the patient then. So when you go to access a port, it is a sterile procedure. We've talked about that. You're looking at the area around the ports for signs and symptoms of infection. So there are some special precautions on page 138 that go along with port care. And generally, the exception is for small patients. Generally, pediatric patients get general anesthesia for the insertion, whereas other patients do not always get that. If a patient is going to be doing home care on their port, they have to make sure that they are taught the procedures and follow-ups, and if they're going to access the port themselves, they have to be comfortable with doing so, especially with the part of inserting the needle through the skin. And they will feel pressure and maybe a little pain, but they've got to make sure that when they do it, that they go all the way to the back of that port so that they hear that needle kind of hit the back of the port there, and they know that they're all the way in, because if they stop short, then the needle could end up in the rubber septum, and there could be a blockage or a slowdown for whatever they're having infused into them. If you remind me on Saturday, we'll get chest out, and you can actually see what a port looks like and what I mean by the way it sounds when the needle hits the back of the port itself. So there are some problems on page 139 with ports. Some simple things like kinked tubing or a closed clamp, clot formations, things like that. And then the inability to palpate it may be that it's deeply implanted. Someone who has a lot of subcutaneous fat, sometimes the port is planted deep in that subcu tissue, and it's really hard to find. Typically, you're going to use about an inch to an inch and a half needle. I have had patients before that have really deeply implanted ports, and I've had to use 2 or 2.5 inch needles. It's kind of intimidating even for you, that if you're used to accessing a port, that you use a needle that long on someone.